My name is Dariusz Borys. I'm orthopedic pathologist at Loyola University Chicago. Today I'm going to talk about bone-producing lesions, benign and malignant. So let's start with benign bone-forming lesions. So today we are going to talk about most common bone-forming lesion of bone, including osteoma, osteoidostoma, and osteoblastoma. Osteoma is benign bone-producing lesion, mostly composed of dense bone. Mostly seen in the skull, followed by paranasal sinuses and fascial bones. Mostly seen in patients in 4th and 5th decades of life. Can be associated with Gardner syndrome, which may present with osteomas, epidermal cysts, fibromatosis, and colonic adenomatous polyposis. This X-ray show osteoma pointed with arrow and present as round, dense, well-defined ivory-like lesion attached to the underlying bone without cortical invasion. This is gross picture, one of my cases, and shows osteoma which presents as dense bone. This histopathologic H&E slide show dense compact bone with prominent Haversian channels consistent with compact osteoma. This histopathologic H&E slide show compact bone with fibrous stroma filling marrow spaces consistent with spongio subtype. Osteoma may be composed of pure dense bone or may be mixed. May present as bone island anostosis. Mutation of LEMD3 gene was described recently. Osteoma rarely recurs and no malignant transformation was described. Surgical excision in symptomatic cases, and differential diagnosis would include reactive bone, exostosis, or parosteal osteosarcoma. Osteoblastoma is a benign bone-producing lesion, highly vascular, sharply circumscribed osteoblastic proliferation that is usually less than 1 cm in size. Some experts say that may be more than 1 cm, but no more than 2 cm. Mostly single intracortical lesion, usually affects young children and adolescents. X-ray film show round central cortical lucency with increased sclerosis, pointed by arrow, of surrounded proximal femoral bone. Next to that is a gross picture which shows targetoid nidus in cortical bone, pointed with arrow. This low-power histopathologic H&E slide shows sharp circumscribed nidus near cortical surface. Nidus composed of anastomosing bony trabecule with vascular connective tissue stroma surrounded by sclerotic bone. Higher power view shows osteoblastic proliferation with vascularized connective tissue and is surrounded by sclerotic bone. Characteristic clinical scenario for osteoblastoma is a child with painful bone, worse at night, and relieved by aspirin. Pain is linked to released prostaglandins PGE2, PGI2, and COX2. Recently, FOS gene rearrangement has been described in osteoblastoma. Surgical removal by curettage is best therapy, and differential diagnosis would include intracortical abscess and osteoblastoma. Osteoblastoma is benign osteoblastic neoplasm, histologically very similar to osteoidostoma, but larger size, usually more than 2 cm, and show more progressive growth pattern. Clinically, usually present as low-grade dull pain, not so intense as in osteoidostoma, and may be relieved by aspirin. Osteoblastoma has predilection for axial skeleton, but may also occur at the extremities. X-ray film show lytic well circumscribed oval or round lesion more than 2 cm with surrounding reactive sclerosis pointed with arrow. This histopathologic H&E slide show proliferation of osteoblasts with woven bone production, osteoblastic rimming, scattered osteoclast-like giant cells, and vascular stroma. This higher power histopathologic H&E slide show again proliferation osteoblasts with woven bone production, osteoblastic rimming, scattered osteoclast-like giant cells, and vascular stroma. This slide show more cellular and busier lesion, but no nuclear pleomorphism or atypia are identified. This H&E slide show blood-filled spaces mimicking aneurysmal bone cyst. Osteoblastoma is benign bone-producing lesion, mainly intramedullary. May show secondary ABC-like changes. Some cases may show more atypia and show more aggressive behavior. Recently, FOS gene rearrangement was identified, similar to one described in osteoblastoma. Treatment with excision and curettage. Differential diagnoses include osteoblastoma, osteosarcoma, and ABC. So now let's talk about malignant bone-producing lesions. Osteosarcoma is a primary intramedullary high-grade malignant tumor in which neoplastic cells produce osteoid. It is important to specify the subtype of osteosarcoma because of tumor grade. Conventional osteosarcoma, telangiectatic osteosarcoma, small cell osteosarcoma, and high-grade surface osteosarcoma are high-grade sarcomas. Periosteal osteosarcoma is intermediate grade, and low-grade central osteosarcoma and parostal osteosarcoma are low-grade tumors. Osteosarcoma is most common non-hematopoietic primary malignant tumor of bone. Most frequently seen in second decade of life, clinically presents as painful and tender mass, mostly large metaphyseal fleshy or hard tumor, unknown etiology, but history of trauma or radiation was associated with tumor growth. Conventional osteosarcoma has three subtypes. Most common osteoblastic sarcoma, followed by chondroblastic and fibroblastic osteosarcoma. Subclassification is based on predominant sarcoma component. In such cases, predominant cartilaginous component is consistent with chondroblastic osteosarcoma, and predominant fibroblastic component is consistent with fibroblastic osteosarcoma. X-ray films show lytic blastic lesion with cortical destruction, sunburst pattern, and periosteal elevation called Codman's triangle and is pointed with the arrow. Next to X-ray is gross picture of osteosarcoma showing expansile metaphyseal centered bone producing tumor mass. This histopathologic H&E section show proliferation of epithelioid to plasmacytoid tumor cells with prominent pleomorphism, atypia, and atypical mitotic figures. Tumor cells are producing osteoid, which is characteristic finding for osteosarcoma. This histopathologic H&E sections show proliferation of epithelioid to plasmacytic cells with prominent pleomorphism producing osteoid, which is highlighted in the center. This MRI image demonstrates mixed, although predominantly high signal intensity of the chondroblastic osteosarcoma tumor, pointed with the arrow. Next to that is a picture of gross showing predominant cartilaginous component in chondroblastic osteosarcoma. This low-power view of histopathologic H&E section shows biphasic tumor composed of cartilaginous and osteosarcoma with predominant cartilaginous component consistent with chondroblastic osteosarcoma. This histopathologic slide shows high-grade cartilaginous component admixed with non-chondroid, mostly osteoblastic osteosarcoma component. There is no sharp margin between two components. This high-power view shows osteosarcoma component with epithelioid to plasmacytoid cells with prominent atypia producing osteoid. This slide shows predominantly spindle cell proliferation with prominent pleomorphism and scant osteoid production, which is consistent with fibroblastic osteosarcoma. Osteosarcoma cells are positive for SADB2, osteocalcin, and osteonectin. This tool may be useful when you have very small biopsy to differentiate from the other tumors. Telangiectatic osteosarcoma is mostly seen in second decade of life. Most of the cases are located in metaphysis of distal femur, upper tibia, and proximal humerus. It is high-grade sarcoma with prognosis similar to conventional osteosarcoma. X-ray slides show lytic lesion with cystic component and cortical bone destruction. Next picture show cystic hemorrhagic lesion with cortical destruction. Histopathologic H&E section shows cystic lesion with blood-filled spaces separated by thin fibrous septa resembling ABC. However, septal cells show prominent pleomorphism, atypia, and atypical mitotic figures, which are consistent with high-grade malignancy. This H&E histopathologic slide shows cystic space filled with blood and surrounded by proliferation of epithelioid to spindle cells with prominent pleomorphism, atypia, and atypical mitotic figures. Findings are characteristic for telangiectatic osteosarcoma. Osteoid production may be scant and sometimes difficult to identify. Small cell osteosarcoma is a high-grade sarcoma with wide range of patient age, but most common in second decade of age. Most common location in metaphysis of long bones. It's negative for translocation 1122, which is characteristic in Ewing sarcoma. This sarcoma has really poor prognosis. X-ray shows aggressive process of the distal femoral bone, destruction of cortex, and sunburst-like features. This histopathologic H&E slide shows proliferation of small round and uniform cells with osteoid production, characteristic finding for small cell osteosarcoma. This is high-grade surface osteosarcoma, mostly seen in second decade of life, similar histopathology to conventional osteosarcoma, but with bone surface location. Periosteal osteosarcoma is an intermediate grade osteosarcoma arising from the inner layer of periosteum. Mostly seen in second to third decades of life, mostly located in diaphyseal area of long bones, with most commonly affected femur and tibia, and has better prognosis than conventional osteosarcoma. This X-ray shows lucent fusiform mass on the surface of tibial bone with mineralization and sunburst appearance characteristic for periosteal osteosarcoma. This histopathologic H&E section shows predominant cartilaginous component in periosteal osteosarcoma. In most cases, periosteal osteosarcoma presents as chondroblastic osteosarcoma. This histopathologic slide shows two components of higher grade cartilaginous component and osteosarcoma component, mostly osteoblastic type. Parosteal osteosarcoma is low-grade osteosarcoma with characteristic location on the surface of the distal posterior femur, mostly seen in third decade of life, arise from outer layer of periosteum, has good prognosis comparing to conventional osteosarcoma. X-ray show mineralized mass of posterior distal femur attached to the cortex with a broad base pointed with arrow. Next is a gross picture showing a similar finding of mineralized mass of posterior distal femur attached to the cortex. Localization is very characteristic for parosteal osteosarcoma. Histopathologic H&E slides show well-formed bony trabecule in a hypocellular stroma. Stromal spindle cells of the tumor show minimal atypia. About 50% of parosteal osteosarcoma may show cartilaginous differentiation. Higher power view show well-formed bone trabecule of woven bone and stromal spindle cells with minimal atypia. Low-grade central osteosarcoma is mostly seen in patients in second and third decades of life. Most common location long bones with predilection for distal femur and proximal tibia. A low-grade central osteosarcoma has better prognosis than conventional osteosarcoma, however, may recur after inadequate resection. When recur, may show higher grade differentiation. X-ray slides show mixed lytic and sclerotic lesion of distal tibia with characteristic sclerotic rimming. This histopathology H&E slide show low-grade central osteosarcoma composed of fascicles of spindle cells with mild cellular atypia arranged in interlacing bundles that permeate pre-existing bony trabecule and medullary cavity. This H&E slide shows variable amount of osteoid production which may present in irregular branching and curved woven bone trabecule. And this higher power view shows spindle cell component with at least moderate nuclear atypia and variable nuclear size. Molecular studies for MDM2 are positive in cases of low-grade central osteosarcoma, and this may be an important tool to differentiate from fibrous dysplasia in some cases. Thank you for staying with me today. There was the short introduction to bone-producing lesions. Thank you.